Well, hi, everybody. I see people coming on to the attendee list. My name is Sarah Schellhorn. I am one of the breast medical oncologists at Smilow. I practice in both New Haven and Guilford, and we're joined this evening by two of my esteemed colleagues, Dr. Susan Higgins. Hey, wave, Sue. And Dr. Paris Butler. Wave. Um, And I will mention, and I'll say this again a little bit later, we were hoping to have Dr. Elizabeth Berger join us as well. She's one of our breast surgeons. And unfortunately, as is often the case, or sometimes the case, maybe not often, she is being held up in an operation right now as we speak, doing what she loves to do. So our apologies on her behalf. We're going to try to speak a little bit toward some of the wonderful work that she does, but please understand, none of us is a breast surgeon. One of us doesn't know how to hold a scalpel, so we will do what we can to try to explain her role. I see some familiar names on the attendee list, so if I know you, hi, it's nice to see you. We're going to start in about 1 minute. Just give everybody a little bit longer to join. What we'd plan to do this evening is each of us has a little bit of a presentation to talk about our specific discipline and how we contribute to the treatment of breast cancer. And then we'd love to open it up to questions from all of you. So if a question arises, jot it down, throw it into the question Q&A section of the webinar. And we'll definitely have room at the end if it makes sense for us to answer it as part of our presentation, we certainly can try to do that too. All right. Well, let me go ahead and pull up my screen. Minimize all of this other stuff. Okay. I am Sue. Paris, you good if I get going?
Absolutely. It looks great, Dr. Schellhorn.
Thank
Go
you.
ahead. Go ahead.
So as I said, my name is Sarah Schellhorn. I'm a breast oncologist, and I'm going to lead us off in celebration of Breast Cancer Awareness Month. We're thrilled to have this opportunity to share with the community, with some of our patients, with people who may not know very much about breast cancer. So thank you for joining us. Breast cancer care is a very multidisciplinary process. It's multidisciplinary, it's complicated. And if we take a woman who has a breast cancer, as shown here with this mammogram, and we start to form our multidisciplinary team from the minute she's diagnosed, and that multidisciplinary team for breast cancer treatment includes a medical oncologist, a radiation oncologist, and a number of surgeons, both a breast surgeon and a reconstructive surgeon. And it starts with diagnostic imaging, which can include mammograms and ultrasounds and PET scans and MRIs and bone scans and all kinds of different things, read by our radiology colleagues. It also incorporates a lot of other disciplines: social work, physical therapy, nutrition, genetics, fertility and reproductive endocrinology. And this is one particular example, that patient might be treated initially with a series of infusion appointments with lots of different chemotherapy drugs. That's under the direction of the medical oncologist, like me. Then the patient might have surgery with the breast surgeon and the reconstructive surgeon. Some of these medical oncology treatments might continue throughout the whole course of someone's treatment. And then a patient might have radiation, which is a number of, we call them fractions of visits for radiation. And all along the way, nutrition, physical therapy, and social work are following along, addressing some of the other, maybe not medical, but other psychosocial needs of the patients. And then following that definitive treatment, we have follow-up visits, mammograms for people who have breast tissue, bone density studies, management of some of the complications of breast cancer treatment, such as lymphedema, bone bone strengthening infusions, more physical therapy. So the treatment really spans the whole patient from start to finish. The goal of each of these doctors and the four of us, well, three that are here, but including the surgeons, the goal of the breast surgeon is to remove the known cancer, obtain negative margins, the area around the cancer, to evaluate the lymph nodes and remove those that are involved. And surgery alone can be curative in a number of patients. And the purpose of radiation is to mop up any cancer cells in that same area that we can't see. This can be administered after a lumpectomy or even recommended in some cases after a mastectomy. The goal is to reduce local recurrence. And I have an asterisk there because there is some benefit in terms of how long people live in certain cases. My goal, medical oncology, is to mop up any cancer cells that might have escaped from the breast, mop up systemically. And the goal there is to lower the risk of what we call distant metastases or distant metastatic disease when a breast cancer comes back somewhere else in the body. And the reconstructive surgeon, reconstructive surgery can take place anywhere along this trajectory, is to restore the breast appearance and address emotional well-being and body image. And I don't certainly mean to simplify any of these disciplines into just this box, but we all have different goals to treat different aspects of the cancer. So I'm going to move a little bit more into my realm and how we decide who gets what in terms of medications. We take a lot of different things into consideration. We look at the tumor stage, the patient's characteristics, how old they are, their medical problems, their own values and preferences. And we take tumor characteristics into consideration as well to make a choice of systemic therapy. And systemic therapy can be multiple things. It can be endocrine type therapies or pills like tamoxifen or aromatase inhibitors. It can be chemotherapy. It can be immunotherapy, such as pembrolizumab or Keytruda. It can be anti-HER2 therapy. It's a lot of different choices that we come up with based on the patient and the tumor characteristics. We often talk about staging in breast cancer, and staging is more than just the size of the cancer and whether the lymph nodes are involved. We now start to incorporate some of the features of the cancer, whether or not it expresses the estrogen receptor or the progesterone receptor, and the grade of the cancer. I'd like to speak just a little bit about that. I don't want to dive too much into the details, but this really drives our decision-making around the biology of the cancer. So when we think about a cancer, we look first at the grade, which is a measure of how aggressive the cancer looks when you look at it under the microscope. If a normal cancer is nice and pretty and round, the more aggressive the cancer, the bigger it is, the more the nucleus, the center, the control center of the cancer is active. And oftentimes, the more aggressive we need to be in terms of systemic therapy. We talk a lot about hormones, estrogen and progesterone, in the treatment of breast cancer because 75% of all breast cancers express either the estrogen receptor or the progesterone receptor. And this tells us that the cancer is fueled, at least in part, by these hormones, these female hormones. And you can imagine that if we were able to block those hormones from interacting with their receptor, that'd be a pretty good way of starving breast cancer cells. So we look at at this piece a lot, and we talk to patients about anti-hormonal therapy. You may have heard of a protein called HER2. HER2 is usually associated with more aggressive cancers, and we have to often be more aggressive in terms of medications for HER2 positive breast cancers. But it also means that patients with HER2 positive breast cancers are candidates for really great HER2 targeting drugs, such as Herceptin, which you may have heard of. So that's a key piece. You may have heard about an Oncotype test. Sometimes people refer to it as, what's your number? And Oncotype is a test that tells us again about how aggressive is this cancer and how aggressive do we need to be. I don't want to spend too much time on that unless there are specific questions about Oncotype. I mentioned that we care a lot about the patient's medical history. Do they have some sort of medical problem that might make it more dangerous or more, we might be more enthusiastic about certain treatments depending on the patient's medical history. We take into account family history and whether somebody has something in their genetics or in their family history that predisposes them to breast cancer. You may have heard of BRCA1 and BRCA2. These are genes that can be abnormal. And if someone has an abnormal gene in BRCA1 or BRCA2, they may have a very high chance of developing a breast cancer along with other cancers over the course of their lifetime. So these are all important factors. Chemotherapy. It's probably one of the most dreaded words in the whole treatment of breast cancer in these conversations. And chemotherapy can range from 12 weeks of chemo to 24 weeks of chemo. It can involve one drug or 6 drugs. And there are lots of different regimens that we choose from. It's very complicated. That's kind of why I have a job. But the spectrum of chemotherapy is incredibly large, and our choices of chemotherapy are dictated by not just the patient and the patient's values, but the tumor itself. In terms of some of the things that we think about from chemotherapy, some drugs that we use very often can have long-term side effects. I will use the first thing on this list, doxorubicin. The other name of doxorubicin is adriamycin. It's also known colloquially as the Red Devil, but it has some rather untoward side effects if used in certain patients and if used to high amounts. So we worry about the heart and we worry about the development of other blood problems. Another common side effect is neuropathy, which is numbness or tingling in the fingers or the toes. That can happen with a number of the drugs that we use. So not only do we give chemotherapy in the short term, but we also have to monitor for some of the long-term side effects that can happen from chemotherapy. So getting a little bit back towards the multidisciplinary nature of breast cancer treatment, we talk amongst ourselves and try to come up with what we think is the best sequence of treatments. Sometimes surgery is first, sometimes chemotherapy is first. Sorry, Dr. Higgins, very seldom is radiation first. But there are advantages to each of these sequences, and a care team would really involve the patient in making that determination in terms of what's best for the particular patient and the treatment of that patient's cancer. I'm going to skip this slide just in the interest of time because my clock already says I'm at 15 minutes. I know I started a little bit late. Endocrine therapy is a major part of what we do. Endocrine therapy or anti-estrogen therapy is generally recommended to almost every patient who has some sort of cancer that's fueled by hormones. And we say that based on the estrogen receptor and the progesterone receptor, which are tested by the pathologists. And we look at, again, the patient and the tumor and make recommendations usually to one of two categories, either the drug tamoxifen or a class of drugs called aromatase inhibitors. And there are lots of side effects, potential side effects from these drugs, lots of required monitoring that we do on these drugs, but we're in it for the long haul. And a medical oncologist will continue to follow the patients throughout the course of years of therapy in an effort to mitigate these side effects, to make life as high quality as possible, and to really work with the patient to come up with what is a tenable treatment plan for patients over the long run. And then patients enter the surveillance and follow-up stage, where they're seeing us in medical oncology anywhere from 1 to 4 times per year. We talk about any interval history. We talk about any lymphedema or other long-term side effects that may have developed during the course of treatment. We don't send people just for routine scans, PET scans, or CAT scans. That's sometimes done with other types of cancer. Instead, we wait for the patient to develop symptoms. And I like to think of symptoms that are concerning from a cancer standpoint as meeting the 3 Ps. Symptoms that are perplexing, you don't know why they're happening. They're persistent, they last and they don't go away, or they're progressive. They start and they continue to get worse over time. It's symptoms that meet those 3 characteristics that we start to think more about, should we do some very particular imaging to try to figure out what's going on with a new symptom. Unfortunately, many women do develop metastatic breast cancer. It's not very many people at the get-go at the first visit, but some women can develop metastatic breast cancer. And breast cancer can go to the bones or the liver or the lungs. And the life expectancy at that time is highly variable. And patients can live for years and years and years with metastatic disease. And the course of their disease can depend on the biology, how well they respond to different types of treatments, and how healthy they are to begin with. One of the exciting things about being a medical oncologist is to see the evolution of treatments over time. And I started my fellowship in 2010, when we had very limited treatment options. I don't list all of the chemotherapies here, but limited treatment options. And since I became a breast medical oncologist, we've seen more and more drugs come into the space of metastatic disease, prolonging patients' lives and really improving their quality of life for years. Most recently, we've got a couple of new drugs that are really exciting. One drug you may have heard of is a drug called Enhertu, or TDXD, trastuzumab deruxtecan. Don't say that 5 times fast. But Enhertu is one of these very exciting drugs that many women are candidates for, as well as other targeted drugs for particular abnormalities that we see in breast cancer. So I love my job. My job is to talk to patients and come up with mutually agreeable treatment plans, to try to eradicate cancer when it's possible, or improve quality of life and make whatever time people have left to be as good quality as possible. I rely a lot on my colleagues in breast surgery and in radiation therapy, to some degree plastic and reconstructive surgery, although Dr. Butler and I don't interact too much. That's kind of my piece of things. And at that, I would love to turn it over, I think, to Dr. Higgins next to talk a little bit more about radiation.
Okay, were we going to go with me or with Dr. Butler?
You're right. Sorry.
I think it
That's
might be
all right.
Dr. Butler, given his time commitment.
Dr. Butler, and just to be very clear, Dr. Butler still has to go back to the OR because one of his cases is still running. So we'll let Dr. Butler go. It is a little bit maybe out of order, but I'm sure that this is going to be really interesting and informative for all of us.
Dr. Schellhorn, that was outstanding for not being a surgeon or knowing how to hold a scalpel. You did us surgeons well, so thank you for that. It's wonderful to see you all this evening. My name is Paris Butler. I'm a Very proudly a plastic and reconstructive surgeon. I actually trained both in general surgery and plastic surgery. So there was a time where I was doing some of the surgical oncology components of breast surgery, and I think it makes me a bit better at what I do on the other side as far as reconstructing breast mounds or doing aesthetic flat closure, which I will get into. As Dr. Schellhorn did mention, fortunately and unfortunately, we still have a case to do this evening. Dr. Berger, who I have the privilege of operating with a lot, she is doing the breast cancer operation right now, and I will be leaving here shortly to perform the reconstruction. So in the interest of time, I'm going to start sharing my slides and give you a primer. And because I do have to sign off, if you want to put any questions in the chat, I will do my best to field them as we go or at the end of my comments. Dr. Schellhorn, Dr. Higgins, can you see my slides? Excellent.
Yes, I
Okay,
can see.
so
Yep.
as I mentioned, I have the privilege of being here on faculty at Yale. I've been on faculty here since 2022. I previously was on faculty at the University of Pennsylvania, a few hours south of here in Philadelphia. I had trained there and I was on faculty for 6 years, and then I was privileged to be recruited up here to Yale in 2022. I serve with 14 faculty in our ever-growing division of plastic and reconstructive surgery. There are 6 of us that perform breast reconstruction within the practice. We do breast. We also do body contouring. We reconstruct literally from head to toe. So diving directly into breast reconstruction, I have the pleasure of giving these webinars from time to time, and I've kind of written down some notes and common questions. So I'm going to use that to kind of get us started pertaining to what us plastic and reconstructive surgeons do in the breast reconstruction space. So the goal, and when patients go in to see and meet with a plastic and reconstructive surgeon, my hope is that all of us, although optimistic, are realistic as well pertaining to what the goal of breast reconstruction is. So we say the goal of breast reconstruction after mastectomy, so that's when the entire breast is removed, secondary to their cancer needs, it's to restore breast appearance and close. Now, I would like to say that the majority of us are adept at making our patients look normal or to restore their breast appearance in a bathing suit. But inevitably, when they take their bathing suit off, when they take their undergarments off, they're going to see the scars. There is no such thing as scarless surgery unless you're operating on a fetus. So the scars will be there. The scars thankfully do fade a lot with time. But really the goal of what we do as far as building new breast mounds is to restore that form and function in clothes and in undergarments. So the next question we frequently get is, how often is it performed? So in the United States, about 65% of the time when a mastectomy is performed, a patient will receive breast reconstruction. This is a little dated, but in 2020, you can see that breast reconstruction operations are fairly common. So in 2020, close to 140,000 breast reconstruction operations were performed. And I'm going to get into the types of breast reconstruction a little later in my comments, but I think it's important to know that this is a very common procedure in the United States and worldwide. So what's the best time? What's the timing for reconstruction? And I did hear Dr. Schellhorn comment on the fact that you can kind of get your breast reconstruction at any point in time, and that's basically true. So pretty much any time, there's a push to do a lot of this reconstruction early on. So we call that immediate breast reconstruction. So that's at the time of the mastectomy alongside with the breast surgeon. Or we can also do it in a delayed fashion. So if the patient isn't healthy enough up front, we can delay their reconstruction so they get their cancer operation, and then we get them a little bit more healthy, we get them a little bit more primed, and then we can perform it later. Or sometimes patients just feel like, wow, this is a lot going on in my life right now with this new diagnosis. I'd rather just take care of my cancer care and then move on with my reconstruction at a later time. The majority, though, of us are doing them in an immediate setting. So who's a candidate for reconstruction? So I would say the vast majority of patients. So any woman who has or is going to have a mastectomy, there is no specific age limit. So women over 60 are welcome to inquire and can receive reconstruction safely. So we did a study when I was in Philadelphia, kind of looking at who was receiving breast reconstruction. We did this national study. It included close to 50,000 patients and identified that there are two subsets of the U.S. community that do not receive breast reconstruction at the same rate as others. And those are our ladies over 50, so our more seasoned in age ladies, and then our ladies of color. So unfortunately, our Black and Latino women do not receive breast reconstruction at the same rate as majority women. So many of us are in the community helping to demystify what breast reconstruction is all about and to help enhance awareness of what reconstruction options there are. And then the question I get very frequently is that, is this covered by my insurance or is this cosmetic? Is this something that they're going to have to pay out of pocket for? So our country did a wonderful thing back in the late 90s. Our legislators across both aisles came together and signed what is called the Women's Health and Cancer Rights Act of 1998. So basically, that legislation mandated that if a patient has insurance and is unfortunately inflicted with breast cancer, their insurance company obviously would pay for their medical oncology and their radiation oncology and their breast surgery. But this legislation also mandated that their insurance company also cover breast reconstruction options. And that also included a balancing operation on the opposite side. So say a patient comes in, right side of breast cancer, necessitates a mastectomy or lumpectomy. We as plastic surgeons can help reconstruct that right side, and we can also perform an operation on the left side to help enhance their symmetry, either while reducing the other side or augmenting the other side in some cases. So is breast reconstruction safe? I get this question a lot also. So yes, breast reconstruction in short is safe. Breast reconstruction does not make the breast cancer recur at a higher rate than if no breast reconstruction was performed. This has been studied over and over again. There are indeed higher complication rates in patients that are smokers, patients that suffer from obesity, and patients that are diabetic. And those complication rates tend to be challenges with wound healing. It also tends to be challenges with infections. Silicone implants have been proven to be safe in reconstruction patients and cosmetic patients, frankly. And if they rupture, they do not cause any additional harm to the patient. What I tell my patients is that silicone breast implants are the most studied implantable medical device ever known to humankind. More than pacemakers, more than knee joints, more than hip prosthesis. Because silicone implants, these same silicone implants that we place in reconstructive patients, we also place in celebrities and we place cosmetically, they are under a tremendous amount of scrutiny. So as a result, they have been studied by the FDA over and over again. So as of October the 30th, 2024, we believe that silicone breast implants are indeed safe in our patients. ALCL, so there's a type of lymphoma, it's called anaplastic large cell lymphoma, that has been associated with textured breast implants. Now, the vast majority of us, when we identified this about a decade ago, decided we were going to take them out of our practice. I honestly don't know of anyone in our Yale practice. I didn't know anyone in my Philadelphia practice that still placed textured implants. So the likelihood was very, very low. 1 in 30,000, I put here, the likelihood of being struck by lightning is 1 in 15,000. But even in light of that, most of us have taken textured implants out of our armamentarium, and we only use smooth, round implants, both silicone implants or saline implants. Saline implants are an implant that has a silicone shell that is filled with saline. A silicone implant is an implant that has a silicone shell and is filled with a cohesive silicone gel. There have been some recent reports of a random and a rare type of squamous cell skin cancer associated with breast implants, also associated with these textured implants. So again, the vast majority of us, not just only in the United States, but worldwide, are not using textured silicone implants anymore. What are the most common methods of reconstruction? Numerous. So I like to call this the continuum of breast reconstruction. So at what we call the most, and sometimes it's not even the most basic, but the least invasive maybe is the aesthetic flat closure. So those are patients who have decided, you know what, I do not want new breast mounds created, whether with an implant or autologous, which we'll get into. I just want things closed nice and flat. We offer that, which I'm going to dive into here shortly. The next kind of most common reconstruction is implant-based reconstruction. And then we have autologous reconstruction. Autologous is to use one's own tissue. So typically it's taken from the abdomen or taken from the thighs in order to reconstruct a breast mound. So quick comments on the aesthetic flat closure. It's becoming increasingly popular. I actually had one last week. I have another one to do later this week. You can see here, this was a study that was performed that was published in Annals of Surgical Oncology, identifying the fact that there's an uptick in the number of patients that are choosing to go flat or embracing going flat. Of these 931 individuals that were surveyed, 22% had commented on the fact that no one had never informed them that aesthetic flat closure was a thing until they didn't find out until they spoke with family members or reached out to another source. And then of the ladies that did receive aesthetic flat closure, close to 75% of them were very satisfied with their outcome. So I get involved with aesthetic flat closures frequently when we have patients who are really concerned that when a mastectomy is performed, they're going to be left behind with a lot of extra skin. I have found this to be tremendously valuable for patients who want to wear a external prosthesis into their bra. That extra skin can be an incredible challenge. The other challenge that we have when we have extra mastectomy skin is that patients can suffer from intertrigo. They can get rashes and irritations within those skin folds. This takes that off the table. So when it comes to, kind of what we think as far as formal breast reconstruction, broken up into two buckets. It's implant-based reconstruction, which we perform 75% of the time in the US. And then there's autologous reconstruction, again, using one's own tissue, frequently from the abdomen. So with implant-based reconstruction, there's saline or silicone options. We frequently will use silicone because they are most lifelike. We also know that they're equally safe as saline implants. There's less rippling. The aesthetic appearance tends to be better. This reconstruction, when it comes to implants, is frequently performed in two stages. That's my preference, or a single stage. You'll hear direct to implant was made quite popular by Angelina Jolie many years ago when she was diagnosed with BRCA and she had a prophylactic mastectomy. So she had mastectomies performed because she had a cancer gene that predisposed her to developing cancer later in life, and she wanted to take that off the table. So she opted to have her mastectomies, and she had implant-based reconstruction where they immediately put an implant in. Fast forward 10 years, we're finding that implant-based reconstruction performed in two stages actually prevents patients from needing further operations later if they just had a single, because it's really hard to get that perfect implant into that pocket immediately after a mastectomy. And then 25% of the time in the US, we're doing autologous reconstruction. So most Americans have some extra tissue to spare in their abdomen. So that's usually the source of the tissue that we go to. So that's what the muscle sparing free tram, or MSF tram. It's the transverse rectus abdominis myocutaneous flap. A lot of language. Or deep flap, which you'll hear thrown out, which is deep inferior epigastric perforator flap. So tissue from the abdomen. The vessels actually come from the thighs and the groin. We take this tissue up from the abdomen in order to make a breast mound, and we do microsurgery to put the vessel together because that flap has to have blood flow. It would not be able to survive without it. Latissimus flap is taking tissue from the back, and then there are also thigh-based flaps for patients that don't have an appropriate abdominal donor site. A little bit more granular about implant-based reconstruction. So two stages, again, which is my preference. I did a few one stages earlier in my career, and I just didn't love the result and decided that two stages is what I thought was giving and yielding the best result. So the first operation, we perform this side by side with the breast surgeons. So they perform the mastectomy. Us plastic surgeons come in. We place a device that looks like this at the top of the screen. It's called a tissue expander. So I tell my patients, think of this as a glorified water balloon. So this is a expander. It's an implant that we can inflate over time. And there's a port in the middle. That's what that metal disc is. And there's a magnet in the back. And we have a cousin magnet in the office. And we literally will identify the magnet in the office. The skin's still fairly numb. We inject a small amount of fluid in there. And over time, we slowly increase that pocket or expand the breast pocket. We then take them back for the second operation. So it requires the second operation where we take out that expander after they've been appropriately expanded and we've gotten them to a size that they like and I'm comfortable with. And then we place a permanent silicone or saline implant. That's the stage 2. So you can see here, this is the stage 1 where the patients come in every 1 to 2 weeks. We use injectable saline to go into the port and we put in about 75 cc's and then we send them home. And then they come back every week or every other week. And I tell my patients, put on a camisole, your favorite blouse or your favorite dress, stare at yourself as much as you've ever stared at yourself before. Come back in and see me the next week and say, Dr. Butler, I like my size, or actually, I think I'd like to be a bit more enhanced. And then we can do another fill. Once we get to the size that the patient desires, we then take them back for that second operation where we take out the expander and then we go through the same exact scar, so there's no new scars, and then we place their permanent, what we call permanent implant. The misnomer about the permanent implant is that the implant's not really permanent. We believe that the implant does have a shelf life of about 10 to 15 years. And at that point in time, the patient needs to go back to the plastic and reconstructive surgeon to have the old implant swapped for a new implant. And that too is covered by their insurance company. We, as plastic surgeons, love show and tell. So this was one of my former patients. She had bilateral mastectomies. This middle picture is her with her tissue expanders in as we're slowly going through the expansion process. And then this picture on the far right is after the second stage of her breast reconstruction where we've taken out the expanders and we've put in her permanent implants. This is a patient who had a left-sided cancer, did not want to have any, opted for a one-sided or a unilateral mastectomy on that left side. We put the tissue expander after the mastectomy on the left. And then when I went to put her permanent implant on the left, I also did a breast lift operation on the right side in order to enhance her symmetry. And then 3 months after that, we performed nipple areola tattooing, which is another great option as far as enhancing the appearance. That 3D tattoo that we performed does not have the typical sensation, but the appearance is as such that we're doing a lot of it, and our patients tend to be quite happy with it. So realities of implant-based reconstruction, it's really for small to moderate breasts, so A to D cup, non-ptotic breasts, so breasts that aren't saggy. It's a shorter procedure. It's about 2 hours per side. It's a shorter hospitalization, like typically 1 day. We're even starting to do some of these as an outpatient. Implant replacement, as I said, is 10 to 15 years when you need a new implant or two new implants. It's not ideal for patients that need radiation therapy because radiation causes that implant to constrict, which we can get into why we do flap surgery, typically for patients who we know are going to need radiation or have had radiation previously. And then if it's a one-sided operation, the patient has to understand that we are very likely going to need to do some kind of balancing or symmetrizing operation on the contralateral or the other side. So flap surgery, again, we typically take tissue from the belly in order to make a breast mound. Those that don't have enough abdominal tissue, we can go to the thighs or the gluteal region and we can make a breast mound from there. It does require what we call microsurgery. It's a much more in-depth and invasive operation. So instead of the 2 to 4 hours that I described with implant-based reconstruction, we're looking more like 8 to 10 hours of surgery and about a 3 to 4 day hospitalization. And the reason for that is because when we take the flap up to the chest and we have to do microsurgery to connect the small blood vessel of that flap to a blood vessel that comes right beneath the ribs, sometimes the flap and that connection doesn't always work. And we need to monitor that flap every hour, every other hour for the first few days to ensure that it's going to stay vascularized and stay open. So again, this is based on blood supply, and this bottom is the actual flap with the blood vessel that's got a clip on it that we take up to the chest to do the reconstruction. Again, some show and tell. This was a patient that I had. We knew she was going to need radiation on that left side. Took tissue from her abdomen because she had some to spare, and I did a flap operation on her left side. I went on to do nipple areola reconstruction on her left side at a later date. So we did this right at the same time as the mastectomy was being performed. And then this was a woman that came to me. She unfortunately had failed implant-based reconstruction at another institution. She found me. She wanted to know if I would offer a flap surgery, which I was happy to do. So I took tissue from her abdomen. She had always wanted a tummy tuck. So we took tissue from the abdomen and went up and made her a breast mound on that right side. So realities of flap-based reconstruction, it's typically for women that actually have some additional tissue to donate. And it's usually from the abdomen. So BMIs of, we would say 27 and greater. It's a longer operation, as I mentioned, with a longer hospitalization. There is a risk of hernia or bulge, and I don't undersell that to my patients. We are robbing Peter to pay Paul, as I say. And the risk of a bulge or a hernia is about 5 to 10%. The risk of that blood vessel connection not working is about 2%. If that happens, God forbid, then we have to not do that kind of reconstruction. And then we'd have to likely either find another flap from a part of the body or go with implant-based reconstruction. It is not for smokers. It's not for the super obese, as that leads to rather significant challenges. These are also patients that tend to be a bit more healthy because you can imagine they need to endure an 8 to 10 hour operation. And then sometimes this operation is sold as a one and done. But the reality is the vast majority of these patients require a second operation for a touch-up in order to enhance their cosmesis. So one of my favorite operations, and this is my last topic, is what about lumpectomy patients? So I commented before that a mastectomy is obviously when the entire breast is removed, but the vast majority of patients have a small cancer and only necessitate a lumpectomy with radiation therapy, otherwise known as breast conservation therapy. So we have been doing more and more of these operations where the lumpectomy is performed, and then we do a smaller reconstruction. So in very large-breasted women who are diagnosed with a smaller early cancer, they may be a candidate for what we basically consider a breast reduction at the time of lumpectomy, otherwise known as oncoplastic breast reconstruction or breast reduction. In my opinion, it's the best of both worlds. It allows a woman to keep her native breast from a reconstructive standpoint. And then from patients who've been suffering from macromastia or breasts that are too large for their frame, neck pain, back pain, shoulder pain, rashes, it also solves those symptoms as well. I want to be clear that despite the fact that we are removing a lot of tissue and we're getting good margins, the patient still necessitates radiation therapy after surgery. So here's an example of a patient who had a left-sided breast cancer, a right-sided breast cancer. She had a small cancer. She had always desired to have a breast reduction. So we were able to remove her cancer, do a breast reduction and lift, because I always get that question too. Dr. Butler, I don't just want my breasts reduced, I want them lifted also. Yes, I will oblige, and we will lift the breast too. And then the patient had radiation therapy. So you can see that the right side's a little bit darker, but her skin actually did quite well. And Dr. Higgins may comment that it's no prize to radiate these really large ptotic breasts. So I've won some favor with my radiation oncology colleagues as well by doing these oncoplastic reconstructions and making the breast mound a bit more reasonable even for radiation therapy. Here's another patient, right-sided breast cancer. We did oncoplastic reconstruction, right cancer removed, breast reduction performed, radiation therapy performed. And then finally, this was an extremely large patient. She actually would not have been a very good candidate for mastectomy and reconstruction because we don't make implants that are so large. And she was considered to be super obese pertaining to her abdomen. So we did an oncoplastic reconstruction on her. She got radiation therapy on the right side and could not be happier. So in summary, we have many options as it pertains to breast reconstruction. I believe that all patients, when they meet with a board-certified plastic and reconstructive surgeon, that they should be offered the continuum, and then there should be shared decision-making pertaining to what they go with. The methods and the timing that fulfills the patient's needs and lifestyle obviously need to be taken into account. So with that, I thank you for your time and the privilege of the podium, as we like to say, and I will turn it back over to my colleagues. Dr. Higgins, I believe you are up next.
I'll go next. I'm going to share my slides. Now, thank you for that, both of you, for that excellent, excellent presentations. I'm going to share my slide. Here we are. I think it should do it now. Let's just move this over. All right. Is everyone able to see that? I'm just making sure. Are you able to see my slides? Okay, great.
All
We sure
set.
can.
Yep.
And you
Looks
guys
great.
can hear me. Okay.
Yes.
So again, thank you very much for those two great presentations. I'm going to speak today. I'm Susan Higgins. I'm a professor in therapeutic radiology, and I'm the director of our Department of Therapeutic Radiology at the Shoreline. And today I'm going to speak to you about radiation therapy and the role that we play in the treatment of breast cancer. I think hopefully I'll be able to demystify things a little bit because I think radiation therapy is a little bit the lesser known of the specialties, and talk to you about some of the new and exciting things that we're doing. So first, I'll start with the most basic principles of radiation therapy, talk about how we do it, um, and then try to focus on our role in the multidisciplinary treatment of breast cancer, as I think both of my colleagues have alluded to. I tell people that, breast cancer treatment is sort of a team sport. We're all playing a role. We're all really focused on working as a cooperative and cohesive group to get the best results for our patients with our respective tools. So I'll talk about breast conservation, which is lumpectomy and radiation therapy. And then I'll talk a little bit about how radiation therapy is used in the post-mastectomy setting for select patients. And then focus a little bit on some of the newer advances and newer choices that we have for treatment regimens, including some shorter courses of treatment for early stage breast cancer. I'd like to speak about one of our favorite technical advances, the deep inspiration breath hold technique. And then two other things that have really, I think, been very helpful to our patients now, which is targeted high-dose stereotactic radiation, which we do for lesions in the body. These are metastatic lesions in the body and metastatic lesions in the brain. So as we've all tried to emphasize, there's sort of three pillars of oncologic treatments. We have the systemic therapy delivered by medical oncology, surgery, both the primary surgery and plastic surgery, and radiation therapy. And again, I think, one looks at these as very interdependent cogs in a complex machine that all work together. With regard to radiation therapy, approximately 50% of cancer patients receive radiation therapy during the course of their illness. And I'm talking about globally, all cancer patients. But, radiation oncologists are very much a key part of controlling cancers of all types. With regard to curative breast cancer treatment, breast conservation therapy we've been doing for many, many decades successfully. It's composed of lumpectomy and radiation therapy, which follows. And as Dr. Schellhorn alluded to, we are sort of the cleanup crew. After a lumpectomy, even though the surgeon has taken out the primary lesion, in the great majority of cases, we're using radiation therapy. I tell people we're like the cleanup crew to take care of any sort of microscopic disease that might be left behind. Following mastectomy, it's a similar concept. After someone has a mastectomy, select patients who are at high risk might benefit from post-mastectomy radiation therapy. Again, we're thinking about cleaning up any residual cells in the chest wall, reconstructed breast, or in the nodes. We sort of call that local regional treatment. And there are indications. Not everyone who gets a mastectomy gets radiation, and we'll talk a little bit about that in the future. But in both cases, radiation has been shown to be really safe and effective treatment that can reduce the risk of local, meaning in the breast, and regional, meaning in the nodes, recurrence by at least 50%. And in certain patient subsets, radiation therapy is actually associated with an increase in survival.
Thanks, Dr. Butler. Dr. Butler has to jump over to the OR.
Oh, I'm so sorry to see you go. All
No
right.
worries. Sorry to
That's
interrupt.
Okay, Dr.
All right, you all
Higgins
take
and
care.
I,
We'll
we
just
have
take it
this
from
all
here.
covered.
Thank you very much. Have a good
Good luck.
evening.
Have a
Bye.
good evening. So in terms of, again, this is part of the demystifying. People really don't know in general how radiation therapy works. Ionizing radiation, when it passes through the tissue, it causes damage to DNA. And in malignant cells, the damage that radiation causes impairs their ability to reproduce. And when they go to reproduce, they die. Normal cells also have are affected by radiation, but the normal cells have the ability to repair DNA damage. So in the end, same dose goes through the tissue, your normal cells bounce back and do well. Malignant cells cannot repair the DNA damage and they die. With regard to how it's delivered, this is pretty much the scheme of how radiation is delivered. Radiation's a high energy photon beam. We use low energy beams to take pictures like chest x-rays, but this is therapeutic radiation. So it's a high energy beam. And with regard to a simple, straightforward post-lumpectomy treatment, you see here that the beam is coming from our machine, which is called the linear accelerator. The high energy beam comes across the breast and across the chest wall. And basically, with these kinds of beams, we could target the breast and or regional nodes. In this case, I wanted to just show how if we sort of did a cross section across the area where someone's breasts are, you can see in cross section that this is the breast. Here's the underlying lung in black, the heart in the middle. And you can see how the design of the radiation beam is such that it comes from an angle. We call these tangent fields. And in doing so, we're able to treat the breast tissue and the underlying chest wall with very little lung or underlying normal tissue, including heart. So it's very specific how we target the breast tissue, and that's, again, one of the ways we make it safe and effective. The treatments themselves are delivered daily over the course of 3 to 6 weeks. And again, we're usually targeting the breast, or in the case of a mastectomy, the chest wall or reconstructed breast with or without regional nodes. But in general, daily treatments delivered over 3 to 6 weeks. So how do we do this? I just want to go through sort of the course of events. Once somebody comes to us and we do our consultation, we decide they're going to need radiation. We start with a thing called a simulation, and it's basically a CAT scan. And at the time we do the CAT scan, we put someone on what's called the breastboard, which is the immobilization device. Because each time we give radiation, we want you to be in the same exact position from day to day. And as you'll see here, the breastboard is sort of like a slant board, and we make people comfortable. But their arms have to be up over their head in these, in a resting position, so that we can basically take the beams and direct them across the body. And so we have this CAT scanner, and that gives us three-dimensional images of the tumor and normal anatomy. And then I go behind the scenes and I take all that information, which goes into a computer, and I actually outline the breast tissue, the lymph nodes, and we basically take that information, and then I develop the optimal treatment plan that ultimately our goal is to maximize the dose to the targets, meaning the breast tissue or nodes, and minimize the dose to the surrounding normal tissue. And I wanted to just show this very basic treatment plan. This is what a treatment plan looks like when we treat a patient who's had a lumpectomy. These are, again, what we call breast tangents. And there's basically, for a right breast here that's had a lumpectomy, we have a beam coming sort of from the patient's left side, a beam coming from the right at an angle. And actually this orange line here is the back of the beam. And you'll see that this encompasses the breast tissue with a very small amount of the underlying lung. And if you projected the field entrance and exit on the patient, it would look like this. Basically, the radiation beams are treating tissue from the midline over to the other side of the breast, and basically it's just above the breast tissue and just below the breast tissue on the chest wall. When we're doing when we're going to treat the breast and regional nodes, we'll use an additional field, and that's what we call a 3-field plan. You're treating the breast with those tangent fields we talked about before, but you add a small field that comes from the front to the nodes just above the breast. So that's a basic, again, treatment after breast conservation for people who might need their nodes treated. And again, it's very targeted and very specific to the areas that need to be treated. In many cases, as we discussed, we do treat people after a mastectomy. In that case, we're treating the chest wall or reconstructed breast. And again, regional nodes with an extra field that's usually above the clavicle and treating the nodes under the arm. The indications for post-mastectomy radiation therapy are many. Some of the things that usually trigger the recommendation for post-mastectomy radiation is positive nodes, a T3 or larger tumor. What we're talking about there is a 5 centimeter tumor, a positive margin if there's tumor left behind on the chest wall, or other combinations of high-risk features, and that could be a half-hour discussion, but I'll just say that post-mastectomy radiation consults are some of the longest because it has, there's some black and white, but there's a lot of gray. So in terms of technical advances, again, the overall overarching goal for us is to maximize the dose to the target while minimizing the dose to the underlying organs, which are what we call organs at risk or normal tissue. And for treatment of, for example, the left breast, the organs at risk are the lung and heart. So when we look at the target versus normal tissue problem, our challenge is that the breast tissue, which I've outlined here in green, lies on the chest wall, and underneath, for example, for left-sided breast cancer, we have the heart, which I've outlined in red, and we have the lung, which is black. And I think, remember, we showed you the angle at which those beams come, but, what we're doing all the time is trying to optimize the angle of the beams. And this, just to give you a schematic, would be sort of the back of the edge of a beam. Our challenge is to treat the heart and lung, treat the target, which is the breast tissue, while minimizing the dose to heart and lung. Now, for many, many years, we have been able to make radiation safer and more targeted by just adjusting the beam. We move the beam, we angle the beam, we shape the beam. But now we have a new thing that we can do to actually change the anatomies and change the relative position of the heart and lung, which are adjacent to our target. So that technique is called the deep inspiration breath hold technique. And it's basically performed by using two components. There's an imaging component, which is actually a surface imaging system. We use cameras to take information about the surface of the body and use that to immobilize the patient and perform treatment. I'm going to show you that now. So the surface imaging is technology for patient positioning and motion monitoring. There's actually a light system in the room. We use 3 cameras, and we're allowed to, what we can do is project a light on the patient's body and check their position prior to treatment with very, very good accuracy. And what we could see here is that there is a blue surface, which is the surface we got at the time we put them on the CAT scanner, and a green surface, which is the surface that we're getting at the time they're on the treatment machine. And those should coincide exactly. But if the patient's arms, let's say, a little bit too far forward, you see the pink, the color will turn up pink, and then you just adjust the arm position and you move the arm and or the body in a way that allows you to treat with and the accuracy of a few millimeters. The other thing we use this for, the surface imaging, is to track changes in the position of the chest wall. And I'm going to show you that in a minute, but I just wanted to introduce the concept of the surface imaging with the lights and cameras that we have in the room. So the process is, we're going to start with that simulation and put a person in the CAT scanner. And this is just a model to show you that what we're doing is, in addition to getting the patient set up for treatment, we're going to capture a surface image and we're going to pick an area on their chest to track. This is where the breath hold part comes in. So when the patient's in the scanner to do the simulation, we actually track a point on the chest wall, and we're trying to monitor that point while they do normal breathing and deep inspiration. So we track it and we have people sort of practice breathing, and there'll be basically exhale here, normal breathing, and then inhale and hold their breath. The idea is to get a tracing like this and figure out what is the maximal capacity that someone can do in terms of holding air in their chest in a reproducible fashion. And we give them a biofeedback system with these goggles. And once you're in the groove of doing your breath hold, you are able to do it reproducibly because we're able to show you a little goal. And basically, this tracking mechanism, we can monitor where your chest wall is and show you if you're in the breath hold, the proper breath hold position or not. And the ultimate, it's a little bit technical what we do, but the ultimate goal is we get a CAT scan with free breathing, we get a CAT scan in breath hold. What happens is in free breathing, you can see this is sort of a picture of a person as if we went down the middle of their body. You'll see the heart and the diaphragm. When you are in free breathing, the heart's sitting on the diaphragm, but when you expand your lungs and you basically, the diaphragm will drop. You could see how the black, which is the lungs here, is much more expanded in the breath hold position. And the heart then moves down and away from the chest wall. And up above, what you see here is that the heart, which is sitting right on the chest wall, has pulled back a little bit. And that leaves us just that extra sort of half or quarter of an inch of room for us to pass the radiation beam under the chest wall to treat the breast, and is very much going to spare heart and lung. And when I go in and do the treatment plan, just to show you again another schematic, we are again going to use a beam that's going to treat the breast tissue and avoid the heart and lung. On the left, this is what it looks like in free breathing. And we're at the edge of the heart, not quite on it. We have a little bit of lung in there. But when we do the breath hold technique, we completely remove the heart away from the edge of the beam, which is shown here in green. The second part of this is once I do the planning, you have to go into the room and we're going to be able to do the breath hold, but we need a system to make sure that the treatment's given only when you're in breath hold. So that's what we call a gated treatment delivery system. And again, you're lying on the table and the patient has the goggles. We have the reference point on the chest wall. We set everything up, make sure everything's in order. And then when you do your breath hold, the treatment's given directed at the breast. If you fall out of breath hold or you're in free breathing, treatment cannot be delivered. The machine is set up so that you can only get treatment when you're in the right position. So I tell people with the breath hold system, it's, icing on the cake. It gives you an advantage and you can't do it wrong. So the bottom line with our deep inspiration breath hold technique is that it significantly reduces the dose to the heart and lung. And what's interesting is it actually, I think patients really enjoy it because it gives them an opportunity to participate in their treatment. And actually, at first, when we got this system, we thought, oh, it's going to make people anxious, or the anxious people have problems with it. But it actually gives people something to focus on and helps quite a bit with anxiety. Some of the advances. So what are the new things that we do now that we didn't do, 10, 15 years ago? Basically, the course of radiation treatments, the standard course has gotten shorter. 20 years ago, we used 6 weeks. Now we've come upon a standard for most people of 4 weeks, which is 15 treatments to the whole breast and 4 treatments to a focused area called the boost. Sometimes, for some people who are at a little lower risk of recurrence in the breast, we use a 3-week course of treatment. That's 15 treatments to the whole breast and no boost. Those decisions are made specifically based on patient and tumor factors. Some of the things that actually Dr. Schellhorn outlined before. How big is the tumor? How aggressive is the tumor? What's the grade? The newest thing is the very short course or ultra hyperfractionated treatment called Fast Forward, and it's given in 1 week. It's offered to a very select group of patients who have early stage disease. They have estrogen receptor positive tumors, and they're at very low baseline risk of local recurrence. I would say that the thing to kind of recognize about this is that it's not necessarily offered to everyone. There are some patients who might not be eligible due to either their tumor factors or due to their anatomy, because we have very strict constraints with regard to the dose to lung and heart when we're giving the treatment in 1 week. So depending on the shape of the patient's chest wall, they may or may not be eligible for the 1 week. But we spend at the time of consultation, we spend a lot of time going through all these options. And again, it's very highly individualized, the treatment. So we go through every factor, and there's some shared decision making and come up with the treatment regimen that really fits you best. So basically the recommendations regarding treatment regimens are highly individualized, take into account many factors, including age, tumor grade, tumor size, the tumor receptors, and there's an emphasis on shared decision making. So I wanted to just finish with a few words about the role that radiation is playing in the treatment of metastatic disease. And I think that this has really actually come to the forefront because Dr. Schellhorn and her colleagues in medical oncology are doing such a great job with the new therapies, that patients are living a long time, either disease-free or with sort of small metastatic deposits that radiation may be able to eliminate. So, as I was just saying, as systemic therapies have improved, radiation's actually become more important, and we are able to sometimes use higher doses of more targeted treatments to optimize control of things within the brain, which we call intracranial disease, or in the body, we call those extracranial sites. So for intracranial sites, we have a wonderful system, the Gamma Knife system, which basically is the mainstay now of how we treat brain disease, and we'll talk about in a minute. For spine metastases, we have a wonderful spine radiosurgery program Dr. Ann is running. And then for other sites in the body, we have targeted stereotactic radiation to specific sites as needed. The stereotactic body radiation therapy, we call SBRT, requires a very high and very precise mode of immobilization, but you can give a very high dose to a small target in a single fraction, and in general, get more durable local control because we're able to give higher doses. And again, these are very select patients. That's the body treatment. Then there's the spine treatment. This is a way of giving very high doses to the vertebral bodies, for example, in the spine. It's very, very helpful for patients who have sometimes one or two lesions that we can target, or a patient who's been irradiated previously and needs some repeat radiation, because we can really shape the dose around the vertebral body, shown here sort of in white and gray, and avoid the spinal cord. And again, we're doing this often for what we call oligometastatic disease, a limited number of metastases, especially at the time of a new diagnosis or in the case of a previously irradiated spine. And finally, the Gamma Knife stereotactic system. Actually, our Gamma Knife is coming back online on the 12th. We just replaced all the sources. But this has really been a game changer for people with intracranial disease. We're able to deliver very high doses with pinpoint precision to multiple brain lesions in a single treatment session. And again, much more durable local control and a significant decrease in morbidity when compared with the standard that we've had for many decades, which was whole brain radiation. So in summary, radiation is an essential part of the multidisciplinary treatment of breast cancer. And with regard to treating the breast and chest wall, it's a very safe and effective treatment that can reduce the risk of local and regional recurrence by at least 50%. And now we are increasingly using higher dose, more targeted treatments such as stereotactic radiosurgery to the body, brain, and spine to control those sites of metastatic disease with very, very high success. So I'd like to thank my colleagues and thank everyone for staying late this evening to hear our talks.
That was incredible. So that was a lot of information. I feel like there's not enough room in my brain for all of that.
Well, thank you. I'm going to stop sharing. There we
All
are.
right. I see a question in the chat from
Okay.
a Mr. Stephen Colangelo, whom I know personally. Hi, Stephen. Post-surgery and chemo treatment, which doctor, oncology or surgery, should be the patient's main driver in the patient's follow-up over the years? Who can read the mammographies, etc.? It's a great question, kind of who becomes the well, I like to call it the quarterback. Once someone with a cure who is treated with curative intent, and curable breast cancer is treated with the surgery, maybe radiation, maybe chemo, maybe endocrine therapy, who becomes the quarterback? In most cases, Sue, I'll go ahead and answer this. Most cases, it's the medical oncologist. Usually because we're the ones providing a lot of treatments. Endocrine therapy, for example, that continues for 5 years or even longer. So we're the ones following patients in the 1 to 4 times a year time frame. That said, we rely a lot on our diagnostic radiologists. So the people who sit in the dark rooms reading the mammograms. I can read a mammogram, kinda, enough to be a little bit dangerous, but we really rely on the radiologists to look at the pictures and give us a good report. So I usually hang on to patients for a long time. Oftentimes, surgeons may discharge patients if they no longer have a surgical need. The hope is that they would never need a surgeon again, and we can always get them back in if they need to see a surgeon. Same with radiation, I think, to some degree. There are certainly exceptions to all of that, where a surgeon and a radiation oncologist might continue to follow patients over time. Great question. Stephen, you got another one? Anyone else? We would love to, any questions?
Sarah, I was just going to add that sometimes I use the baseball analogy, and people are like, when they come in with their diagnosis, they're like, who's doing what? And so I
Right.
say, well, I said, if you look at it in this way, it's like a baseball team. You're the manager, and then you make the lineup. And I come out and I pitch, but then I go back in the bullpen.
That's
And
right.
after all the people come out and do their job and they go back to their, to their place, I think, again, we still think of you as the manager of the manager of the team.
That's right. That's right. Now, a much more difficult question is inflammatory breast cancer. What is inflammatory breast cancer and why is it special? Or how do we treat that differently? I'm again happy to start, but Sue, how do you view inflammatory breast cancer as being different than, like, what is it and how do you view that any differently than kind of a run-of-the-mill garden variety small breast cancer?
Well, again, I think, usually these cancer cells are more aggressive, and when patients come to us, they have particular appearance of their breast. And as opposed to something that's sitting in the middle of the breast tissue, these cells often go to the skin area. They could be more extensive, spread throughout the breast. And in general, they need I guess I would say they usually need all 3 of our therapies. There's usually no question about that.
Yep.
I'll let you add what your thoughts are about
Yeah.
that.
So inflammatory, I agree with all of that. Inflammatory breast cancer is when someone shows up with a breast that's red or inflamed or warm, kind of makes it look like it's an infection, something called mastitis, like an infected breast. It looks like that, and it develops very rapidly in a short period of time. These cancers that create inflammatory breast cancer are, as Dr. Higgins said, very aggressive. They tend to be very aggressive. They tend to infiltrate into all of the little vessels, blood vessels and lymphatic vessels in the skin. And so the treatment is also very aggressive, including usually chemotherapy first, chemotherapy specific to the biology of the cancer, a big surgery, a modified radical mastectomy, which is removal of the breast, and an axillary dissection, removal of a lot of lymph nodes in the armpit. Usually no immediate reconstruction. So someone like Dr. Butler would not be involved right off the bat, followed by radiation, and then any endocrine therapy if needed, or anti-HER2 therapy if needed. So a more aggressive cancer. There are there's some literature and some theories that it represents a subtype in and of itself, that there's something about these cancer cells that makes them so aggressive. Probably not for this purpose, for this forum to discuss more, but a much more aggressive cancer that requires much more aggressive treatment. All right, I won't pimp you anymore, Stephen. I know a number of you. I could call on you. I won't
Uh-oh.
do that. I won't do that. That's so mean. Um, just Stephen. The um, I as always, we are delighted to share and to talk to patients, to caregivers, to the community. And while we hope we never actually meet you in clinic, because no one wants to get to know either a radiation oncologist or a medical oncologist professionally, um, we, if you need us, we are here for you. And please don't hesitate to reach out with any questions. I think we're going to be posting some additional content with Dr. Berger's piece. I know she certainly is sad to be missing this, but as with all of us, our patient care comes first. So I think with that, Eliza, unless you have anything else that we need to say, we can wrap up for the evening and enjoy your evening. Happy Halloween. Stay safe. It's supposed to be warm tomorrow. Not sure what to do about that while we're trick-or-treating in our felt heavy costumes. But hope everyone has a wonderful fall, and best of luck to all of you.
Thanks very much.
Thank you.